Well, thank you for attending this meeting, and that is a time for questions and answers. Thank you very much, Annette, Octavio, Andrea, and Adrian, for explain a little about the work package to pre-screening. We are focused only in the pre-screening, and as you can say, MOPEAD is working well. Has a good health now, have a good health. At the first, no, but now have a good health. But the important things that we are learning here is the 4 different scenarios has interpreted or representative for the different countries in the different way. Maybe, I don't know, maybe citizen science using the website, it's a so novelty, pioneering way for engagement patients that it's not include very well in the Spanish society, Adrian, because it's completely working different from Spain and the other countries. Maybe because we have no culture using the e-tools, but the most important for MOPEAD and the results of the MOPEAD, we need to implement the e-tools for engagement patients. That is an open question for you. The secondly, open house initiative that Octavio told is easy to understand because it's a face-to-face using the neuropsychological tools in a memory clinic. Maybe for a neurologist and the practitioners, is very well known to deal with the patients, and the protocol even include around 40 minutes, Octavio, 40 minutes more or less. 40 minutes. It's not one peanut chat. It's in a moment we have the diagnosis. No, we invest 45 minutes to understand or to test if the memory is touché, is the memory has the faults. But maybe for every country, for the neurologist has, we are involved in memory clinics, open house face-to-face is more usual and it's introduced very well in our culture. The most important thing that we are learning in this mid state from the pre-screening, in the pre-screening process is how PCPs are not involved in the engagement patients. What the PCPs don't like lead with memory complaints or mild cognitive impairment. As Octavio say, because they have no time, because they have not well training, or maybe because we have no treatment. But this is reluctant, because if we don't understand the weight of mild cognitive impairment in the continuum of Alzheimer's disease, it was impossible, completely impossible, to find a treatment for prodromal Alzheimer's disease. We need to be generous for the patients, generous for the families, understand, and to be very well trained, very well informed, no fear for Alzheimer's disease, and to talk and to involve PCPs in this important project. It's not MOPEAD project, it's Alzheimer's disease project. PCPs must be involved in Alzheimer's disease project, and MOPEAD is one tool to use for these benefits. Last time, endocrinologist, Andrea and the group, it's very proactive because they know very well how it's difficult to lead with patients with diabetes, with memory complaints and with memory defaults, because it's a big and important and increasing health problem, public health problem. If I don't treat well my diabetes, because I lose memory, I increase comorbidities, conflicts to manage, and increase the problems from the health problem. That is my question for you, and that is your time for the questions, if we have an answer. Thank you very much. Time for the questions. Oh. 1 question, 2 questions, 3 questions. Wow, fantastic. Maite.
First of all, congratulations, because I think it's an amazing project. My question is for Andrea. I'm quite curious how people say no when you ask them for memory testing when these people have diabetes. So if I understand you very well, you say that it's less than the 40% of people say yes, only the 40%.
Yeah.
And you say that an explanation could be related with the comorbidity, but I think it is enough to explain that?
For the patient, yes, it is enough, because most of them, they already have the diabetic foot. No, they have a coronary heart disease, they had a heart attack, they had a stroke, they have a very complex treatment and take a lot of pills. They just don't want another health problem. They just don't want to tell them you have a memory problem, you know? So they say yes to my pre-screening, and then when I tell them, oh, you might just have a cognitive impairment, you might go to the memory clinic, and they say, no, I'm okay with that. So I don't want to proceed. And this is a real challenge to explain them that it's really important for me to know is that if they have cognitive impairment in order to simplify their treatment, no, or
maybe you should work on that way if we know that this is a problem. But
trust me that
big deal
we are
for all of us. Okay. Thank you.
Thank you.
Thanks very much. Hi, I'm Cesar Rodriguez from Scotland. I'm just following that premises of the difficulty of getting diabetic patients followed up in memory clinics. Could it be that the system that we have is not conducive with polymorbidity being referred to every single different specialty? That is, if you have a diabetic service, why not being able to offer all the complications of diabetes within the same clinic? So us, as diagnosticians, move to whatever the patient is rather than the other way around.
I'm really glad that you asked this question, but first of all, we have to recognize cognitive impairment as a diabetic complication. So in order to make the strategy and to offer the patient the full screening and the full battery of tests. But you know, including in our colleagues, among our colleagues, there are a lot of them that don't believe that in the relationship between type 2 diabetes and dementia. So I think that first of all, you have to deal with that problem, you know?
And may I just ask a second question? Is regarding the IT-based recruitment and the open house. When you get people into the studies through that, how do you liaise with primary care?
Sorry, can you repeat, please?
Yes, when you get people recruited through the IT system and the open house, which is directly to memory clinics, how do you then liaise or communicate with their own general practitioner, with primary care?
Okay, it's up to the patients. I give the diagnosis to the patient, the medical report, and I ask him if he wants me to upload the report in the system.
Right.
So my communication is not in patients from round 2 is not with the PCP, is with the patients.
Yeah. I was just wondering if that also made the primary care physicians to feel a bit outside the normal process of diagnosing dementia.
Yeah, but you know, we are exploring different strategies, and in fact, one of these strategies completely focused on primary care system. So, as it is not a referral from PCP, I need to ask the patient if he wants me to communicate it to the PCP.
Thank you.
Thank you. This is just some clarification. The title of the project, Alzheimer's disease and other dementias. So we're talking about dementia, not just Alzheimer's disease, which takes me back to the the prevalence for memory problems with people with diabetes. Do you mean vascular dementia?
In my presentation in the slide, I meant Alzheimer's disease because yes, it's true that type 2 diabetes increases the risk of vascular dementia, and it is well known, but the problem is that increases more the risk of Alzheimer's disease, and the pathophysiological mechanism they share common pathways, you know.
As well as vascular dementia?
More than vascular dementia, I would say.
Okay, so I just think that could be clarified because you mean all dementias, not just Alzheimer's disease, don't you?
Yeah, in my opinion, the literature about that is quite confusing because it's mostly based in epidemiological studies, which doesn't include a deep phenotyping of the participants. But actually, there are several studies that found that diabetes really increases the risk not of all types of dementia or vascular dementia, but specifically of Alzheimer's disease. I think thanks to this project, we are going to learn about these people because we are going to perform a deep phenotyping with MRI, biomarkers, etc.
Hello, my name is Mark Wortman. I have a question here in the back. With the open house approach, you recruited a lot of people through the internet. Do you do anything to keep them engaged once they are registered?
Well, this is the challenge in round one, the online tool, because you don't have this face-to-face or engage after having after communicating this risk. You have to just provide all the information to the citizen in order to keep going with the study. So this is the point where the citizen has to decide if it's okay to go, and I want to know more about my deficit or my cognitive impairment, or I don't trust this tool, or I just go to my PCP. It's a problem very similar, I would say, in other strategies. We are seeing that in some point the decision is on the citizen.
I have a question for you. What do you think that for package 5 could be? No, I have a question for you. That no, it's not working.
This is working.
Yes, I finished my question for you. I finished because it was impossible to talk with you. And my question for you is, how hard could be to inform an education about how important is to detect memory timely for the global population? Do you think that the effort of World Packet 5, how to reach a whole population, implement for the families, patients, PCPs, diabetologists, everybody who needs to be involved?
Shall I try now? Sorry. Yeah, I think that at the end of the project, we will have to bring some recommendations for not only the policymakers, but also for the professionals and also the patients and their families. But the idea is that at the end of the day, we need a big awareness campaign about the disease and the value of an early diagnosis. And also from another perspective, trying to engage people to get engaged in clinical trials and make sure that by their engagement, they can help us understand more the disease, how it progresses, and how it can be treated. It's certainly something that we need to plan at the end of a project based on the outcomes of the different recruitment strategies, looking at what works best, what doesn't work so well and why, and try to improve that. But at the end of the day, make sure that what we get from the benefits of this project is brought out to the public, and we build on that. That's a longer-term strategy that we need to devise at the end of the project.
Another question?
Hi, thank you very much for the talk. I would like to know if you have analyzed what are the motivation or the concerns of the people that did complete the screening, because are they aware of memory problems, or do they have history, family history of Alzheimer's disease?
Well, we are not collecting this as a variable, but of course we talk with all the participants, and I think there are two very different type of participants. Those coming from Run 1, the online tool, and coming from Run 2, the open house, have a completely different motivations than the people coming from Run 3 and 4, because they came voluntarily because probably in the majority of cases they are worried about their memory. And this is not the case in our experience in Run 3 and 4, because this is people who went to their PCP for another reason, probably to check their blood pressure or sugar, and suddenly is faced with this new opportunity. So I think that these are two completely different groups of participants.
Well, time is off. Thank you very much. But before to finish this session, I want to thank FGF and Laura Campo for their job and their support for all this project. IMI from the European community, all our partners, and especially in this occasion, Alzheimer Europe for offer this opportunity to explain a little more what is MOPEAD and what we are learning with MOPEAD, and of course, all the panelists, our partners, and all of you. Thank you very much. Enjoy Barcelona and have a good Alzheimer conference meeting. Thank you very much. Okay.